Hello, and thank you for joining me. In this video, I will be providing you with a brief overview of the Chapter 10 coding guidelines within the ICD10CM codebook. The Chapter 10 coding guidelines reviews the diseases of the respiratory system, which classify to category codes J00 to J99, and code U07.0 is also included here. Our first diagnosis we want to discuss is COPD and asthma. So specifically, the acute exacerbation of chronic obstructive bronchitis and asthma. So these codes classify to categories J44 and J45. And basically, it just breaks down whether or not the diagnosis is uncomplicated or the patient is in an acute exacerbation. There is a brief definition provided to you here that an acute exacerbation is a worsening or a decompensation of a chronic condition. Keep in mind that an acute exacerbation is not equivalent to an infection superimposed on a chronic condition. An exacerbation could be triggered by the infection, but the provider documentation is key here. We must have the provider documentation in order to fully code out an exacerbated condition. Our second diagnosis we are going to discuss is acute respiratory failure. Now, the basis of these guidelines for acute respiratory failure is how to sequence them. Is it going to be principal diagnosis or secondary diagnosis, or do they have another condition that is also present? A brief overview of what all of these mean, all three guidelines for acute respiratory failure, is: does the patient meet the definition of principal diagnosis? Okay, so if the patient comes in and the patient is meeting that principal diagnosis definition, that the condition established after study to be chiefly responsible for occasioning the admission to the hospital. The condition is present on admission, so it could be assigned as principal diagnosis. However, sometimes a patient could come in with pneumonia and 2 days later go into respiratory failure. You can sequence this as a secondary diagnosis as well. So it does qualify as either a principal or a secondary diagnosis, but you need to make sure that you are choosing your principal diagnosis correctly. And again, this goes, it's the same as if another diagnosis or acute condition is also present. And this is within guideline 3, and it provides an example of a myocardial infarction, CVA, and aspiration pneumonia. So the principal diagnosis, it's not always going to be the same in every situation. So if you see acute respiratory failure and pneumonia, you do not automatically assume, acute respiratory failure is going to be sequenced first. That's not the case. It all depends on, why the patient was admitted, what was really going on during that initial admission time, and that workup and treatment. So please make sure that you do reflect back on the reasoning, the principal diagnosis, what that definition truly is, and if the patient meets that principal diagnosis definition. The next section is influenza due to certain identified influenza viruses. So we want to code only confirmed cases of influenza that could be due to a specific type of influenza. This could qualify under category J09 or J10. Now, this guideline, it is an exception to the hospital inpatient guideline. So in this context, confirmation, it doesn't require documentation of a positive lab test for a specific type of influenza. Our provider can diagnose this and document it whether or not they have the lab test available. So it does not require a positive lab test. Now, if the provider does document, say, suspected, possible, probable, again, we should assign this as if it was confirmed if it is within an inpatient setting. based on the inpatient guidelines of coding uncertain and improbable diagnoses. Our last set of guidelines is in reference to ventilator-associated pneumonia. So with all procedural and post-procedural complications, the code assignment is based on our provider documentation and the relationship between the condition the patient has and the procedure. So code J95851, ventilator-associated pneumonia, should be assigned only when the provider has documented the ventilator-associated pneumonia, also known as VAP. Okay, we can also code an additional code to capture that organism. Is that organism that's present? Is it E. coli? Is it streptococcus? Is it MRSA, etc.? We can code that additional organism under the B96 codes. We do not want to assign an additional code from categories J12 to J18 to identify the type of pneumonia, because if it's vent-associated pneumonia, that's what we capture for that pneumonia. J95851 should not be assigned for cases where the patient has pneumonia and is on a mechanical ventilator, and the provider has not specifically stated that the pneumonia is vent-associated. If the documentation is unclear, then we want to basically ask our provider to clarify this. And we would do that through a provider query. Vent-associated pneumonia that develops after admission. So a patient could develop one type of pneumonia, so J13 pneumonia due to streptococcus, and subsequently develop vent-associated pneumonia. So in this instance, the principal diagnosis would be the appropriate code from category J12 to J18 for the pneumonia diagnosed at the time of the admission, and then code J95851 would be assigned as a secondary diagnosis to document that the patient developed that vent-associated pneumonia after admission. And lastly, vaping-related disorders. This is a new guideline this year. For patients presenting with conditions related to vaping, we want to assign U07.0. And this is vaping-related disorder, and it could be as the principal diagnosis. For lung injury due to vaping, we assign only the code U07.0, and then assign additional codes for other manifestations such as respiratory failure or pneumonia. Associated respiratory signs and symptoms due to vaping should not be coded separately because we have that definitive diagnosis, and we will not code any signs or symptoms when our definitive diagnosis has been established. However, it would be appropriate to code separately any type of GI symptoms such as diarrhea and abdominal pain because it's not a common respiratory symptom. Okay, so, but if it's cough, shortness of breath, and the patient has it documented as due to vaping, we would not code cough or shortness of breath separately. And that is all of the guidelines for Chapter 10, our diseases of the respiratory system. Thank you for joining me.